Hi, listeners.
Hello. Welcome to the Med Insights Unleashed podcast
With your hosts,
Z
and John.
Hi, John. Again, it's great to see
Again today.
I know.
It's been exciting.
It's been, you know what? It's because you went to ASCO. You did such a fantastic job and all the meetings that you had and posters that you took in and data that was presented. ASCO is just a wonderful platform. And as such, we've now been able to produce all these episodes with fantastic speakers. So it's great. It's good.
Yeah, we've had many firsts on Med Insights Unleashed, many first data point presentations from our international speakers. And we have another first data point presentation from two great doctors that I met at ASCO, standing at their poster, trying to mind their own business and hide.
And of course, you're like, hey, how's it going? Let me ask you.
And I just thought, oh, that's exactly what I thought. And I thought, this poster looked very interesting. And when I started reading it, it was about melanoma, which is really close to my heart. I met these two doctors, and I'll have Jacob and Ellie, or Elinor, introduce themselves regarding their passion, which is around this poster at the moment. And they're both doing exceedingly well in this field. So, Ellie and Jacob, would you like to introduce yourself to our audience? Because you have a lot to offer today in a disease state that is pretty deadly to a lot of people globally. And in Australia, it's one of the highest skin cancers that have the worst outcomes of death in Australia. And that's the country where I come from. So, as I said, this disease, melanoma, is very close to my heart. So please go ahead.
Yeah.
So I'm a PGY2 internal medicine resident at the Health One HCA program in Lone Tree, Colorado. I went to CU Boulder for my undergraduate, and then I got my master's as well as my medical degree at Rocky Vista University, also here in Denver, Colorado. I'm interested in pursuing a hematology and oncology fellowship. So I had the wonderful opportunity with my now attending, used to be co-resident Jake Keeling, to present at ASCO this past year, where we got to meet John. And that's how we kind of ended up on this podcast. I'll let Jake go ahead and introduce himself.
Yeah. Thanks, Ellie, for the ups on making it through residency. I'm Jake Keeling. Initially went to medical school at the University of Oklahoma, kind of for my whole undergrad and professional education. I've been really interested in cellular biology and molecular biology and drug development. So that kind of put me in a lab for several years before I got into the Sky Ridge residency program. And once I was there, we were able to form a really good connection with Sarah Cannon Research Institute, who was running a lot of these phase 1, first in human clinical trials. We got to know each other. We liked each other well enough and decided to take on this project and write it up and get it into ASCO. And that's how we got where we are today.
First of all, congratulations, Jake, on getting through your residency. That's a great feat. And also out of Sarah Cannon too. We did a lot of research over the years with Sarah Cannon, and what a fantastic institution and cancer center Sarah Cannon is.
Yeah, it really is.
Before we jump into the actual data, Elinor, I thought it'd be valuable for the listeners because you mentioned an acronym. You said you're a PGY2. So could you describe what that is? And then perhaps just share with those residents that are out there how you kind of came to the concept of your research proposal and, for others that may be interested in pursuing something similar.
Yeah, definitely. It's not an easy feat, getting into research when you're a resident, when you're working long hours, working all the time. It's definitely difficult to also think, if I want to pursue this fellowship, that I also need to kind of be thinking about extracurriculars and research. Luckily, I have a wonderful mentor who is sitting here with us, Jake Keeling, who I reached out to kind of within my first few weeks of residency and told him I'm really interested in oncology. And he has provided me with every opportunity available to kind of help me get there. He's also taught me how to write. So, a lot of research, we do a lot of writing. And I think learning that technique has been difficult, but having someone who has been a mentor to me and can kind of help me along the way, as well as guide me through going through fellowship applications, is a really helpful value to have in a residency.
Wonderful. Wonderful. Thank you.
And why melanoma?
So great question. We kind of, as Jake mentioned, we came across this project more so because of the connection that was made with Sarah Cannon. And they had this project and these really exciting results, and they needed some residents to kind of help write it up. And of course, us being the eager to residents we are, we said, we'd love to help kind of write it up. So that's really how it came about.
Melanoma is, as I said from Australia point of view earlier, is one of the deadliest skin diseases globally, as well as in Australia. So could you just give the listeners some insight into melanoma and then why it became your passion from a research perspective? I know that you said that you picked it up at Sarah Cannon, but you developed this great poster with this data, but it would be great to have the listeners with the background in melanoma.
Yeah, definitely. So starting kind of from the basics, melanoma is a neoplasm of melanocytes. Melanocytes are cells that produce pigment melanin, and we find these melanocytes in our skin, as well as in our eyes, as well as in mucosa. So there's kind of three main histological subtypes of melanoma: cutaneous, so being the ones in our skin, mucosal melanomas, as well as ocular melanomas or uveal melanomas. This is pertinent information for us because two of the patients in our study had uveal melanoma, which is so the
Wow.
ocular melanoma, and then
Yeah.
three of them had the cutaneous melanoma, so in their skin. Completely different when we talk about kind of risk factors. So when we think about, sunlight, UV radiation, people having increased risk for melanoma in Australia, that's linked to the cutaneous melanoma, but there's no correlation with the ocular melanoma. So the ocular melanoma, we think of genetic predisposition. There's also genetic predisposition for cutaneous melanoma, but the UV radiation does not correlate with the uveal melanoma. The most fascinating thing to me about melanoma and cancer in general is really research that we've seen within the past, 10 to 20 years. So prior to, I'm going to give you a little history lesson here, but prior to 2011, the median overall survival rate in patients with metastatic melanoma was 6 to 9 months. And the 5-year overall survival rate was less than 10%. Since the introduction of immunotherapy and targeted therapies in 2011, we've seen that overall 5-year overall survival rate be now in metastatic melanoma patients be 50%. So it's really revolutionized. It's amazing. I think it's what continues to draw me into this field is just, these exciting new research, this exciting new research coming out. So that's kind of a little bit about the background of melanoma. So yes, immunotherapy has revolutionized melanoma. However, there's still more research to be done because one of the biggest things that we see with immunotherapy is immunotoxicity. So those adverse events that patients will get, they're a little bit higher with the CTLA-4 inhibitors versus the PD-1 inhibitors, which are now our standard of care for treatment for metastatic melanoma patients. Regardless, I think a very exciting thing that we'll kind of share about our study today is the really few adverse side effects that we saw.
Can you talk about those side effects that you see with immunotherapy and CTLA-4s?
So immunotherapy, there's many types of immunotherapy. So we think about CTLA-4 inhibitors and PD-1 inhibitors. Those are both checkpoint inhibitors. cancer cells, they're very smart, they're very sneaky, they like to sneak past our immune system. And checkpoint inhibitors essentially prevent them from sneaking past our immune system, and they allow our immune system to go kill those cancer cells. So we've always known for a long time that our immune system will, fight off kind of foreign things. However, sometimes those cancer cells will sneak past that. So those checkpoint inhibitors prevent that. However, it's a systemic drug that you're giving. And so it can essentially attack anywhere in the body. I once had an attending tell me the way that we think about immunotherapy side effects are you think of all the itises. So you think of dermatitis, colitis, pneumonitis, anything with an itis, it can cause it. But really it can cause, inflammation and irritation of anything, any organ in our body. The most common ones are the dermatitis. So a lot of patients will end up with rashes, pretty significant rashes. They can end up in the hospital with pneumonitis. So those are the big side effects that we think about with immunotherapy.
But typically, as a result of immunotherapies being around for such a long time and clinicians having so much research experience as well as clinical experience, they are better able to manage and step in terms of handling the side effects, correct?
Yeah, definitely. I think, from my experience, the mainstay of treatment is usually you just stop that inflammation. So you're usually just giving them steroids to kind of help that inflammation. But yeah, like you're saying, it was 2011 was that big year when those CTLA4 inhibitors came out. And then shortly thereafter, the PD-1 inhibitors. So they've been out for a while now for people to really learn about the side effects and how to manage them.
So these CTLA-4s, or I know the immunotherapies moved to the neoadjuvant adjuvant setting. Can you explain the treatment pathway for a melanoma patient?
Yeah, definitely. So when someone kind of presents to their primary care physician, maybe with an odd looking mole on them that is new, usually what will happen is most likely it'll go to kind of a dermatologist to get a biopsy which is just a sample of that skin tissue. When we get a sample of that skin tissue, there's many different kind of histological findings that we'll get from that, but biggest one I'd say is the breast slow depth is what we call it. And so that will essentially tell us how deep is that melanoma gone. And it gives us prognostic factors. Also, it gives us a lot of information of how do we further manage this. So is this something where we need a sentinel lymph node biopsy because it went so deep that we're concerned that it has metastasized? There's a lot of other factors kind of within the histological findings that we'll get, but those are usually the steps that are taken if they're concerned about that the cancer is spread, so metastasized, then usually they're getting more imaging for concerns about where has it spread and ruling that out. And then, depending on, what stage it's at, then that will kind of guide where they go for treatment.
You just want to quickly overview the staging so patients understand, like, there's early stage.
Yeah, definitely. So from, my understanding, like I'm not an oncologist, I'm not a dermatologist, just a quick little disclosure if I didn't already mention that. But usually when we think about kind of early and late stage, I'd say late stage is really thinking about melanoma that has metastasized and spread to other places. And at that point, we're looking at more kind of systemic treatment, but it really depends on the patient where those metastases are. Sometimes you treat, if there's liver metastases, there's special therapies that can be done to directly treat those liver metastases.
Go ahead, Jake.
Okay. Yeah, sorry. I was just going to jump in a little bit there. Yeah, basically the goal with melanoma, whenever you find it, first things first, you want to be able to cut it all out. The problem is if it's invaded past that Breslow depth that we view as dangerous, we think that cancer then goes to the lymph nodes, which is kind of our next larger generalized category for that spread melanoma. And you can still try and cut those out by basically finding what those lymph nodes are and then removing them, looking at them under the microscope. The problem that you get a lot of the times is that once a melanoma's gone to the lymph nodes, it's already gone all over the place too. And even if you take out those nodes, there's a good chance that melanoma will crop up somewhere else, like a different spot in the skin or the liver or basically any other organ. And that's where we talk about distantly metastatic disease, which was kind of the case in almost all the patients that we worked on in our trial, them only being 5. But they were all those late phase melanomas. And obviously, when your melanomas popping up in random places where you can't expect, cutting it out surgically no longer works. So that's where we look for these new treatments.
Yeah, I think what was amazing about your trial is that these patients were resistant to ICRs or immunotherapy or CTLA-4s, and that was normally, if that happens, the life cycle is really palliation. And now your data, even though it's very preliminary and it's got to go through a lot of research to actually get approved by the department and randomized phase 3 trials, it's so exciting because of the responses and the depth of responses that you got in these resistant patients.
So I
Yeah.
think it's kind of a good segue if Ellie, could you maybe set up the trial that you guys worked on? Because again, immunotherapy, as you just mentioned, is the standard of care for these patients, achieving 5-year overall survival, like you said, of roughly like 50%. So now the goal is, okay, how can we increase that? So do you need to walk us through like the concept of the study and then maybe like key components of the study?
Yeah, definitely. Like you said, this was kind of thinking about kind of the progression of melanoma over the past 10 to 20 years and how much has been done. It's great. It's incredible. It's, to see kind of such an increase in an overall survival rate. But our introduction to really, I think, talking about and one of the big purposes of this new drug, this antibody drug conjugate, is the fact that there is so much immunotoxicity still seen with the immunotherapy and affecting patients' kind of quality of life and permanent kind of immunotoxicity that you can see. So I'll let Jake kind of give the introduction of our study drug on kind of the mechanism of it.
Yeah. And absolutely, before I even jump into the drug, you guys are 100% correct. I think one of the big trials showed that almost 2/3 of patients on this immunotherapy that works for a ton of patients have really pretty severe side effects from it. And then on top of that, that's just not even counting the patients who fail that drug, who, like you said, are now back to square one where we were at those abysmal survival rates. And so everybody has kind of been looking for drugs to treat these patients who fail immunotherapies. What's next? And to do that, a lot of people have been looking for cancer specific molecules that we can target antibodies to. The molecule that we targeted for this particular trial is called ROR2. ROR2 is an acronym for something really esoteric that doesn't matter too much. But basically, research has shown that this protein gets upregulated in cancers like pancreatic cancers, squamous cell carcinomas, and melanomas. It gets especially upregulated whenever these cancers start to spread to distant sites. And it turns out, looking at what is this protein for, because all of our cells have it, when we're little embryos, it helps us develop into the proper shape and structure. So we don't need it so much as adults. So it's really downregulated in all except a couple tissues. But the cancers bring it back whenever they want to spread. So that was kind of the impetus for targeting this molecule. So one other thing that's particularly interesting about this drug is that not only did they target this embryonic protein, but it's pretty well known that cancers are just a little bit more acidic than other cells because they can't handle basic processes like waste management as well as other cells can. And that acid changes the 3D structure of this protein just a little bit to make it just a little bit more unique than necessarily a healthy patient's ROR2 might be. And so what BioAtla did, who developed this drug and who we are not on the payroll of, they actually targeted an antibody to ROR2, but not just ROR2. They targeted it to an acidic ROR2. So now not only is it hitting this rare protein, it is hitting a rare structural form of a rare protein, which makes that antibody even less likely to hit your normal cells, which is where we see classic chemotherapy side effects from because it just kills everything. And so, yeah, that's basically the gist of this drug is it is an antibody to that acidic ROR2, and it has a little business end of chemotherapy called Vedotin attached to it. And so that antibody seeks out the cancer cell, binds to the acidic ROR2, and it delivers that chemotherapy directly to the cancer using a fraction of the dose that it would normally take to attack a drug because we're able to use this guided missile approach to attacking the cancer cells.
That was a great.
It's amazing, isn't it? It's incredible.
Yeah, it's very cool.
I love your description of it too.
Yeah. Can I ask a question? Because, okay, so let's say if a listener's listening, they'd ask, does it have to be a acidic form of ROR2? Could it be a non-acidic form?
That's almost a little bit of the shtick of the drug is because there is still a little bit of ROR2 in our bodies. The blueprint of it was found in thyroid glands and the actual protein was shown in human colon, healthy colon. And that is the ROR2 that exists normal pH at a non-acidic form. And yeah, there may be, actually there probably is a very small, but hopefully clinically insignificant binding of that non-acidic ROR2. The cancers, because they are dysregulated, dysfunctional cells, they specifically produce this acidic form. So we want it to look for it. And you would not always find a cancer that you would expect to be perfectly normal. And if you did, you may need to go to the drawing board and find a different drug because this one seems to be fairly specific for the acidic ROR2 just based on the side effects that we see and how minimal they are.
It's amazing that you brought up because you also said that this exists, this antibody drug conjugate is working in squamous cell. It's also in human papillomavirus of the head and neck. Are these cells, these three cells, melanoma, human papillomavirus, and squamous cells, more prone to develop the acidic form?
Yeah, that's a great question. And so I don't know if it was mentioned earlier, but yeah, the big new news with this drug is it was approved for phase 3 trials in squamous cell carcinomas of the head and neck that are associated with HPV infection. And really what we would expect to see is that any cancer that forms a solid tumor of any significant size is going to outgrow its blood supply. And that will contribute to how acidic the environment is within it.
Of course.
Yeah.
Hypoxia.
So that's why it's good for these particular cells. And every cancer is a little bit different. Every, genetic complement available to each cancer is a little bit different. So nothing's universal, but it's been seen commonly enough in the cancers we've talked about to obviously pursue investing and researching this drug with good results.
So, Ellie, would you like to, or Jake, to actually talk about the study now and what your results were?
Go for it,
Yeah,
Ellie.
definitely. So we had a total of 5 patients 2 of those had uveal melanoma, and 3 of them had cutaneous melanoma. What we saw was 4 of those 5 patients had a decrease in their target lesions. So the way that we kind of measured response to the drug was through imaging. So either CT scan, PET scan, both MRI, and we figured out kind of target lesions per the RECIST criteria. The RECIST criteria is just kind of an objective measure that you use for solid tumors to kind of determine response within those tumors, and you're just measuring the size of them. So we measured kind of throughout the drug, the study drug that they got, and would kind of determine their response to the drug. What we saw was 4 of those 5 patients responded, meaning that we saw a decrease in those target lesions. So we took an image at the beginning and then throughout, and we saw a decrease in size of 4 of those 5. 2 of those 4 that responded were incredible results. So one of them is still actually, at the time that we published or presented in ASCO, was still on the study drug. The other one of those patients had a complete response. The highest was 89%, and a complete response 2.5 years after completing the study drug. So
That's amazing.
yeah, it truly is amazing. I'll back up a little bit, but the inclusion criteria getting into this clinical trial was metastatic melanoma refractory to prior treatments. So somebody, prior to 2011 had a survival rate of 6 to 9 months and now was 2.5 years off of the study drug and still had a complete response.
Ellie, I think he's, we spoke to his current oncologist. He's closing in on 5 years.
Wow.
No.
Yeah.
Wow.
So this was a first. Okay, so your patient number was an N of 5. So
Mhm.
this was a first in human study, so a phase 1 study.
Yeah.
You mentioned that patients had received prior treatments, which again we know is immunotherapy highly likely. Were there other what role did prior immunotherapy play in terms of the eligibility criteria? Do they have to have 2 lines, 3 lines, more, less?
None of that really played. All of them had at least 2 prior. Many of them were also on clinical trials prior and had failed those clinical trials or had progressive disease with those previous clinical trials. So there wasn't any, specific, you need this number of, prior.
Yeah.
Yeah.
It is important
Which
to mention, though, that every single one of them had immunotherapy and had progressed on it.
And
yes, that's what got me about the study
Right.
is that, you're getting immunotherapy used very, very early now in treatment, and then you're getting it used again when they go to first line, second line, or whatever, and with CTLA-4s and combinations. These patients are resistant to all of that, which is
so
incredible.
was the study randomized? Patients had received, was it in combination, was the ADC, the anti-drug conjugate, with an immunotherapy like nivolumab versus single agent? Was that the study
Yeah.
design?
So that area gets slightly more nuanced. It's harder to do something truly randomized when you only have 5 patients. The major criteria for this particular drug was just that everything else had failed. And unfortunately, there was an arm of this trial that had some co-administration with one of the immunotherapies, nivolumab, just because of the way things worked out and patient tolerances. Only one of our patients was co-administered nivolumab. This was also a patient who had, I think, at least 6 lines of therapy, which every line of therapy you give a cancer, you kind of make it a little stronger. And he unfortunately progressed with his disease very shortly after initiation of the trial. So I don't think we can really, in good conscience, discuss what we think might happen if we combined immunotherapy with it. We need more data there. Ours were primarily with our drug alone.
Thank you.
Okay, how did you administer the drug and for how many cycles? I mean, I know it's on the poster, but the patients and the listeners can't hear read the poster. So
It'd be nice if, we could show poster up and
Yeah.
fly out to ASCO, do it all over again. So it varied, how many cycles kind of each patient got. It was anywhere receiving the drug via intravenous infusion every 2 weeks or every 3 weeks. And some of the patients did have to we lowered the dose, or they would hold the dose due to kind of personal reasons as well as side effects. However, what's really notable with this drug is that no patient ever had to stop the drug because of adverse side effects.
so I've got two questions. One is that you've mentioned multiple times before, the side effects for immunotherapy. So can you describe the side effects associated with this drug? And B is, what really is a phase 1 study? And explain what a phase 1 study is for the listeners, because they hear about phase 3s. They don't hear too many podcasts or episodes about phase 1 studies. So maybe you could explain that too.
Do you mind if
Yeah.
I hop in, Ellie?
Go for it.
All right. So first and foremost, whenever a drug is ready to come out of a mouse and into a human being, you run through these multiple phases of drug approval. We start out with phase 1, which is primarily just to determine, is this drug safe and does it work in humans like it does in mammals? Like you said at the very beginning of the episode, John, if we had a nickel for every drug that cured cancer in mice, we'd have a whole lot of nickels. But it pretty rarely translates for a number of reasons that we aren't here to discuss today. But that's what the phase 1 is primarily there to determine is, does this work? Does it have horrible side effects? So you use a small number of patients and you tinker with the dose across these few patients to see, can I get a good clinical response? And do I get really bad side effects? Once we know it's safe, we then move into the phase 2, which is even more of the tinkering to focus on how well can we make this work and stay safe. Phase 3 is more or less when we've decided that, okay, we're convinced that it works, we're convinced that it's safe. Let's make sure in a larger number of people. And then from there, you're looking at phase 4, which is just sort of continued monitoring of the drug over time, even after it's released. So that's sort of the phase trial. So we are looking at a drug that just came out of the mouse room and into the clinic, which makes it, doubly exciting for me and Ellie, I think, to hit those side effects. So what I told you about before, the little chemotherapy molecule attached to that antibody called Vedotin,
Yes.
it kills cancer by attacking basically the scaffolding of a cell. It's called a microtubule. It kind of holds the cell in place and helps it migrate and all that stuff. So this drug stops it from functioning properly. And so with that drug, that's kind of where our side effects come in, because a very, very small amount of that chemotherapy drug will break off of the antibody. It'll break off of the guided missile system and float around and then kind of hit things indiscriminately. 2 areas of our body that are particularly vulnerable to that particular type of medication are the nerves, because great big long cells that travel from your spinal cord to your legs need a lot of microtubules so they can make that trip properly. So you get neuropathy, which we needed to reduce the dose a couple times on. The other area where it can hit you is in the immune system, because those immune cells divide very, very quickly. And microtubules are also the things that hold the DNA in proper places when a cell divides. So you can see some of your white blood cells go down too. we can usually treat that away like we did in our patients with a drug that just makes them divide faster. But those are the primary side effects. The neuropathy is by far the most distressing to our patients, and the
Mm.
low white blood cells the most distressing to the doctors.
There are other nanoparticle tubule inhibitors like paclitaxel, etc., on the market. So
Absolutely.
maybe it's not unknown, and that there is a very good management process in place at the hospitals and the doctors and the nurses to manage those side effects. I think it's important for patients to understand this is not an unknown side effect.
Yeah. And in fact, even
Point.
our one patient who's been on the drug so long, with the stable disease of the eye, she actually needed to go down on her dosing because of that neuropathy. And after a little bit of a pause of treatment, recovered as well. Our gentleman with the complete response, he actually decided that the tipping point for him to go off the drug completely was he didn't like the neuropathy anymore. So he wanted to have it watched, and the neuropathy actually went away after a few months off treatment. So it certainly can be permanent, but our 5 patients, it was not.
Hmm.
And so you make a good point here, Jake. You're the patient with the complete response
Yes.
opted not to continue on therapy because of the neuropathy. But did the study require, like the study inclusion, was it that you would treat patients to disease progression, right? Or was there a set number of cycles for treatment?
Y- In cases like this, especially in your phase 1 trials that are looking for patients who have a disease that has run rampant on everything else, it's just not terribly humane to give them a drug that's working and then say, "Oh, time's up, time to take it away." So there's usually a good conversation going on between the makers of the drug and the people running these trials. And I am not Gerald Falchuk, the head of drug development at Sarah Cannon, who actually has those discussions. But generally speaking, if a patient's doing well on a drug, it's not going to be taken away from them, especially in a phase 1.
Right.
Hmm.
Okay. So patients and what was the primary endpoint? Was it response, I'm assuming, of this trial?
Response or disease progression.
What happens now with this study in melanoma? Where do you go, Ellie? What's your role moving forward? Is your work done here? You and Jake, he's just passed his exams. Well, what's the future?
Yeah, I don't hear from Jake anymore. He's living attending life, making attending.
Oh, you stop that. He hears from me too much.
You gotta throw a little humor in there?
I know.
Right. No. So I really hope that my work is done. You know, as I mentioned before, I'm really interested in pursuing a hematology and oncology fellowship. And as I mentioned, Jake has helped me get there. As well as, he's helped me build this relationship with Sarah Cannon Cancer Institute. And so I hope to kind of continue to kind of write up any research that they have. Obviously, I'm a resident, and so I have to be realistic about all of this, but I hope that my work is not done with them. Jake, do you want to chime in?
Sure. The melanoma work, first thing that we need to do is there are a lot of little centers, or little relatively, like Sarah Cannon, who are testing this drug in this same phase 1, 2 sort of trial scenario. So all that data from all those centers needs to be aggregated so there can be more than just 5 patients that are discussed. From there, it is up to BioAtla to decide what to do with that drug, but I am hopeful that these results obviously carry through to other melanoma patients and they can pursue that in their own time. But for the time being, I think their big focus is pushing through the phase 3 trial, which is, larger numbers of patients with those squamous cell carcinomas of the head and neck with HPV positivity, which is also a desperately needed treatment group. HPV has been causing more and more cancers as time goes on. I believe their data that they currently had on squames showed what they were able to get at least disease control in 17 out of 20 patients. And again, this is another cancer that kills people if it skates through immunotherapy. So it's exciting times for them. And I bet you Sarah Cannon will continue to try new drugs and new and interesting ways. And Ellie's in a perfect spot to help them. And I'll help
Yes,
her. But
definitely. Just on the head and neck, Ozuriftamab just presented the first trial in the adjuvant setting in a randomized phase 3 trial, the first trial that was successful in cutaneous squamous cell carcinoma. That was presented at ASCO by Danny Rishin. And he actually, when his presentation, said this is still a high unmet need, and the disease is over. When you're looking at patients with skin cancer, squamous cell carcinoma is many more incidences associated with squamous cell carcinoma than there are of melanoma. So it's a significant disease globally.
yeah, yep. Everybody should get their HPV vaccination, gentlemen included.
Yeah.
Yes. And so from both of you, I had, well, two questions, and I know it's up to companies to kind of pursue the development, but given the high rates of response in such a highly refractory patient population, would you anticipate or, could say, hey, you know what, this is worth kind of pursuing earlier lines of therapy for melanoma?
Yeah. I mean, I think you get into the unfortunate realities of nickels and dimes and how many man hours can you devote to a particular project when you have a set group of employees at a drug development company like BioAtla. But having spoken with their people there, I have every reason to believe that they have both human and other incentive to pursue this drug and in every avenue they can. And if it gets fully pushed through for squamous cell carcinomas, that drug is on the market. It's here to stay. And then it is just sort of moving the goalpost, so to speak, to get it into other cancers from there.
It'd be nice to have a drug like this that's with minimal inverted commas around the minimal side effect profile to make it more acceptable for patients, for their quality of life. That would be really, really nice to have. I'd like to do a push for melanoma myself. So that they should continue on with their research in melanoma.
Absolutely.
Okay, is there anything in the study that we haven't discussed that you thought, is earth-shattering and other than the results and the toxicity profile? I mean, the durable responses we've already talked about, side effects we've talked about. Is there anything else that you would like to talk about on this with this particular agent and ADC?
Yeah, I mean, for me, the really kind of exciting part on my end was that I don't know if you call it a breakthrough or a paradigm shift of, oh wait, these proteins aren't specific to the cancer. Let's just go for a different pH and use that as a surrogate for a unique protein.
Yeah.
I think that's just a super exciting thing that can go to many more therapies past ROR2. And sky's the limit on where that can go, as long as we can get an antibody to it, which is most places, luckily.
Right.
So I'm really hoping to see this conditional antibody technology make it into new therapies down the road for other hard to treat cancers. I think it's really exciting.
Absolutely.
Good. What about you, Ellie?
I feel like we're saying, our rose and thorn are like favorite part about the study. But my favorite part, and I think most fascinating thing to me, was really, as we've already talked about, but this long-term disease control in patients who previously, had like less than a year for their median overall survival. So I think to see someone with such long-term disease control after stopping the drug is incredibly impressive and just speaks to kind of, why I love oncology, why I think it's such an exciting field as well, because we continue to see this progression and continued research.
Usually what happens when we close off on our episodes, we ask one or two of you to talk about the three most important points that you get out of this poster, which you may have already summarized, but if you could condense that to 3 points.
Yeah, take it away, Ellie.
I'll share one and then I'll let, Jake chime in as well with his all the mechanisms.
Teamwork. Teamwork.
Exactly. So talking about kind of the three takeaways from this poster presentation that Jake and I presented at ASCO, I would say one of the key summary points was the adverse side effects and looking at kind of when we compare immunotherapy, that is now our standard of care for melanoma, we see significant adverse side effects that affect patients' quality of life and cause them to be unable to complete the treatment. With the antibody drug conjugate that we have presented at ASCO and talking about today, we're seeing minimal adverse side effects, and we had no patients withdraw from the study because of the adverse side effects.
Very important point.
Two, I'll let Ellie hit all the enthusiastic, perfectly positive notes. A point I would make, especially to patients listening. One, this is working in really difficult to treat cancers, and it's working in more than one cancer type, which is exciting. Temper that with the reality that we still only have the data in a relatively small number of patients. So 100%, if you have disease right now that is not responding to other therapies, this is a good avenue to look at. We are not done doing the research on this drug yet. And that just has to be said just for reality's sake.
I got a question. Before you go to 3, you brought up a really good point, which we haven't talked about. How does the patient get into the trial?
Love that question. So for anybody listening who may be wondering, there are centers across the United States, not just Sarah Cannon, they're at universities, and these places are running phase 1, phase 2, and sometimes phase 3 clinical trials. Oncology is a really research-heavy specialty, so a lot of them are involved. Your oncologist will help you make the decision if you need to be looking for a clinical trial. Your oncologist should also be able to then help guide you to the appropriate place to get that experimental drug if you are at that point, and you may not be. And jumping to the experimental drug is not always the correct choice when you have something at hand that works. So trust your oncologist. They'll help you.
That's great. I like that. I love that.
So for
John's signaling. He's like, we have 1, we have 2, we need 1 more, guys. 1 more key takeaway, please.
Yeah, Ellie.
So I would say the last important point to really think about here, as I've probably mentioned many of times already throughout this podcast, but the long-term disease control that we're seeing in patients with refractory metastatic melanoma. I also kind of want to add 3.5 here. We had uveal and cutaneous melanoma patients. So all of these statistics that we're talking about that I've been kind of mentioning throughout this podcast, we're on cutaneous melanoma patients. When we go to uveal melanoma patients, it's even, lower kind of overall survival rates. So I think that that's important to kind of recognize here that it's both cutaneous and uveal, and that we're seeing still long-term disease control off treatment.
And uveal is a rare form, correct? Like it's a
Yeah.
rare form of melanoma of the eye.
Yes.
Thanks, John. John's pointing. So sorry for the listener. Uveal is ocular, like eye form of melanoma.
Yeah. So about for all the melanomas, 90% of those are cutaneous, so the ones that come from our skin. And then about 3 to 5% are the uveal melanomas. And when you look at the amount of research that's out there, there's obviously a lot more for cutaneous melanoma because about 90% of melanomas are cutaneous. However, that doesn't minimize that there still is research that needs to be done on uveal melanoma.
Last point before we close off, Ellie, and this is again a question to you. In your position within the hospital system, right?
Mhm.
How important is a good mentor?
Great question.
Very valuable. Great question. And I say this to Jake over here. I would not, only the bad things are said now. I would not be here without Jake Keeling. I know that kind of I am a very ambitious person and I want to be here, but Jake has allowed me to kind of get those steps to be here. He's taught me a lot. I think to any resident that is interested in pursuing a research heavy competitive fellowship, it's important to get experience within research and also just go to conferences. I had the lovely opportunity to meet John, and that's what led me to being here. It's overwhelming going to those conferences full of, 40,000 people at ASCO?
Yeah.
Crazy. But it's kind of a look into why this field is so exciting, the amount of research that's being done. And for me, it really kind of, lights me up to go to this and say, this is really what I want to go into.
Wonderful. That was a great question, John. Thank
It
you. Yeah, good question.
So on behalf of our listeners, Zara and myself, Med Insights Unleashed, we're very proud to have you with us. And what a great conversation, and congratulations to both of you. You're always welcome back. So make sure that you tell your other interns and residents that they're welcome here on Med Insights Unleashed. We get the message out. And there's also diseases that we want to talk about, like lung cancer and other diseases. So if you've got friends in those areas, we'd love to have them on as well.
And thank you for sharing this amazing, groundbreaking data research, because these are the conversations that John and I used to have. And, it's great that we have found a platform whereby patients, aside from ASCO, where patients and caregivers can actually become aware and it helps empower them. So really appreciative for both of you sharing this groundbreaking data. So thank you.
Completely independent of pharma as well.
Yes.
Yeah, it was a pleasure to be here, and Ellie and I have talked about it multiple times. We agree so sincerely that medicine is not some labyrinth of nonsense. It does take years of training to understand it, but you should be able to explain and then a patient should be able to get what's going on with their body and why doctors are doing what they're doing. So we are thrilled to help you with that mission.
Thank you.
Med Insights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. Med Insights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next Med Insights Unleashed podcast.